off we go.
Right. Thank you, Barney. First off, it's nice to see everyone, very familiar faces and also new faces. It's nice to actually speak at the coffee morning as a guest about a little over a year since I left Southampton. So a bit of a disclaimer. During my talk, I might switch to the term CEI, otherwise known as community engagement and involvement. I just want to tell everyone that CEI and patient and public involvement, or PPI, are the same thing. However, the NIHR makes this distinction. So the term used for research projects in the UK, we use PPI. But for global health, meaning outside of the UK, we use the term community engagement and involvement to emphasize the importance of community structures in, I guess, non-European, non-UK cultures. So just a bit of a disclaimer. Next slide, please. So today I'll be talking about one of our projects, one of our studies that will have a lot of community input. So I work for the NIHR Global Health Research Unit on Global Surgery. I just call it the GSU, the Global Surgery Unit. We are funded by the UK government through the NIHR, and we are hosted at the University of Birmingham in the West Midlands. But we do have research hubs across different low to middle income countries. So we have hubs in Benin, Nigeria, Ghana, India, South Africa, and Rwanda. So I'll be talking about species and how this pertains to our different research hubs outside of the UK. Next slide, please. Quick outline of today's talk. I'll be discussing who we are, so what the Global Surgery Unit has done so far. What have we planned to do for 2023, and in particular, how the species study fits within our upcoming trials this year. Next slide, please. So Barney, could you just let all the text out? Thank you. So the main purpose of the Global Surgery Unit, again funded by the NIHR, is to improve surgical outcomes in what we call LMICs, or low to middle income countries, through collaborative research. So the Global Surgery Unit was founded in 2017. We got funding for 5 years, so we were able to obtain 6.9 million pounds. We were refunded in 2021 and have funding until 2026. So we were given 7 million pounds. So as previously mentioned, we have 7 hubs and more than 80 hospitals connected to it. So our research structure follows a hub and spoke model. So each country has a main hub hospital. It's usually a tertiary or a teaching hospital. And then they have connections with smaller hospitals. So this actually helps us improve our reach when we do research. And so what are the research themes that we focus on? The first one, and I think the most important, would be preventing surgical site infections. When the GSU was funded, we spoke to surgeons around the world, and the number one concern that they had were surgical site infections. So majority, if not all, of our studies are focused on preventing post-surgical site infections. The second one, and this is especially after COVID, would be waiting lists and surgical delays. So the problem of waiting lists and surgical delays is not just happening in the UK, it's also happening around the world, especially in lower resourced hospitals and healthcare systems. Another research project we're focusing on are hernia surgeries. So hernias are actually the number one, they're the number one elective surgery that has the highest demand. And in Africa, the country with the highest demand for hernia surgeries is in Ghana. So we have a trial that aims to equip non-surgeon doctors, so GPs, skills on how to perform hernia surgeries, just because they have a shortage of surgeons there. We're also focusing on keyhole surgeries and green operating theaters. So for context, a third of the carbon output of a hospital comes from surgical theaters. And what we're trying to look at, we were able to get funding to do a few studies in the UK, is reducing carbon outputs from surgical theaters, operating theaters. Now, the question is, can this be applied to other contexts outside of the UK? So we have a PhD student working on this. Finally, rural surgeries and community health workers. So community health workers are trusted members of the community. They're not medically trained, but they serve as liaisons to, say, a district hospital and a village. So this is where a lot of CEI or PPI comes in. Can you actually utilize the expertise of community health workers in patient care, especially when patients are discharged in the community? So that's the scope of what we do. Barney, next slide, please. So what have we done so far? I'll highlight two studies and how it, and I'll try to explain how it latches or connects to what we're going to be doing in 2023. So we knew that surgical site infections were quite important because they're an issue, but we didn't really have that much evidence. So there's very little evidence published about the occurrence of surgical site infections. So what did we do? So in 2018, we collaborated with 66 countries and their healthcare practitioners there to find out what was the rate of occurrence of surgical site infections among patients there. Please click. All right. So we looked at 12,539 patients across 343 hospitals in 66 countries. And what we found out was, next slide, Barney. Thank you. Yep. So I'll just go, I'm going to use my pointer. Oh, I can't. So what we found out was surgical site infections can occur from as high as 14 to 23% of patients in low to middle income countries, meaning 1 in 5 patients who are about to undergo surgery in low income countries will get a surgical site infection. That's quite problematic because, number one, that means longer stays in hospital, and longer stays in hospital means they can't start work. And if they're the sole breadwinners, then they're not able to provide for their family. So there's a knock-on effect. What's even more disturbing is that up to 36% of surgical site infections in low-income countries are caused by drug-resistant bugs. So that's, again, quite problematic. And we published this in 2018. Next slide, please. So we knew that surgical site infections occur in a significant proportion of patients in low to middle income countries. What can we do then to actually help prevent that? So in the West, normally, when a patient is opened up for surgery, just before they're sutured and closed, the surgeons will change their gloves and instruments. And it's a practice in a lot of hospitals in the UK, in Europe, in the West. However, there isn't a lot of evidence proving that it can actually reduce surgical site infections. So we, last 2021, GSU started a trial called CHEETAH, which aimed to look at if the change in gloves and instruments can actually reduce surgical site infections. So we looked at 13,301 patients from 81 hospitals, and then we basically compared what was the rate of surgical site infections in the usual practice where you don't change gloves and instruments versus changing instruments and gloves prior to suturing up the patient. Next slide, please. And what we found out is that by simply doing this, there's a 13% in SSI reduction rates by simply changing gloves and instruments. And so we're actually looking now at the health economics aspect of that, because the whole idea here is to change policies. Go to ministries of health and tell them, maybe you should implement this. But to do that, it's not enough that you have scientific evidence. You need to look at, okay, is this actually cost effective? So the paper about the trial has been published. It was published in the Lancet October of last year. The health economics paper will be published in the next few months. Next slide, please. So these are all the trials and studies happening at GSU. It's a veritable Noah's Ark of animal named studies. So I won't really go into all of these, but a lot of these, the objective is to reduce surgical site infections. Next slide, please. So what do we plan to do in 2023? So we plan to do two important studies. The first study is called SWAN. And the main purpose of this is to look at a new kind of dressing. It's a dressing that's routinely used in some European countries. Next slide, please. That contains what you call sorbact. So unlike regular dressings, which contain antibiotics which burst bacterial cells or germ cells, sorbact actually draws out these cells from the wound. So instead of bursting or killing the cells, causing release of toxins and inflammation, sorbact actually just draws these germs from the wound. So we want to find out, are sorbact dressings just as effective or even better than regular dressings? And then DRAGON is a trial that aims to look at, and this is in relation to having a more green operating theater, the use of single versus reusable drapes or gowns. So we want to find out if reusable drapes and gowns, which you need to launder, are they more effective or as effective as single-use drapes and gowns in reducing surgical site infections? Next slide, please. So where does species come in? So the study that I'll talk about. So essentially, we know that surgical site infections can, number one, increase mortality rates or death rates in patients. We know that this can actually lengthen their stay in the hospital, and it can cost the hospital system or the healthcare system more. However, there are knock-on effects of surgical site infections outside of the hospital because it can affect carers, communities, families. It can have psychological, social, and financial effects, and even delay the return of work of patients. There's a lot of literature that says health literacy can actually help prevent surgical site infections, especially once patients are in the community. But the evidence that's published so far mostly come from high-income countries. What about low to middle-income countries? So that's where this study comes in. So the main objective or objectives of species would be to compare the quality of life of patients who've had a surgical site infection and patients who did not develop a surgical site infection. And we want to assess the levels of awareness of surgical site infections and self-management. The idea behind this is, if we know the baseline levels of awareness and health literacy, we can actually co-develop with the community materials that can help raise awareness of surgical site infections. Next slide, please. If you could just, yes, perfect. So how does this fit into the two trials? So first, what we plan to do is trial participants in SWAN and DRAGON, the two trials I previously mentioned, will be invited and consented to join this study. And what do we plan to do? Simply plan to ask participants in this trial questions from what we call a validated questionnaire. It's called the PROMIS Global Health Scale. The beauty of this is, number one, there are lots of translations available. We are working with 7 countries with multiple languages. And this really short questionnaire will work seamlessly with the workflow of the trial. And it will ask them questions about what do they feel, what's their mental, how do they feel in terms of their levels of anxiety, in terms of their worries about the surgical wound, about their worries with regards to return to work. And we will also be asking a few questions about what do they know about surgical site infections? Do they know how to manage their surgical wounds? And do they know who to contact in case an emergency happens? And we're going to be asking trial participants or we're going to assess them during 3 periods in their care journey. Number 1 would be before the operation. Second would be during discharge. Now, discharge will depend on the kind of operation, but on average, it's about a week or a week and a half after the surgery and during their 30-day follow-up. So 30-day follow-ups in low to middle income countries can sometimes be face-to-face, but in some instances where the hospitals are really far, we've actually developed from our previous trials a way of doing a follow-up over the phone, where we can assess if a patient has had a surgical site infection based on answers to a few questions that we modified from the CBC. So yes, and after this big survey, we will be getting 1 or 2 patients per country, and we're going to be conducting qualitative interviews to actually find out their experiences of SSIs outside the hospital. Next slide, please. So this is just the questionnaire. It's quite short, and it's been validated, and we have translations. Now, most important thing, what do patients think about this study? So we did, of course, we did a lot of PPI on this. Next slide, please. So what did our patients think about this study? So we conducted PPI or CEI meetings in all our participating hubs. So Benin, Rwanda, Nigeria, India, and Ghana. I forget. And so what did they think? Next slide. Okay. So we consulted with 157 stakeholders. I know we don't like using the term stakeholders in the UK, but in global health, that's what we use. And so this is the breakdown. We consulted with about 29 SSI patients, 19 carers, 88 community health workers, and 21 community or opinion leaders and village chiefs. So pretty good spread. A little bit more community health workers. It's because we do have a lot of contact with them. And so we asked them the following. Number 1, what did they think about the study? Was it acceptable to them if we asked patients these survey questions at 3 points during the trial? Comments on the questions and the wording. And they wanted to find out, are there additional questions, or we wanted to find out if there are additional questions that we should be asking. Next slide, please. So what were our findings? Number 1, everyone was in agreement that the effects of SSIs go beyond the hospital, and that SSIs, specifically patient experience of surgical site infections, are a priority. We showed them translations of the survey tool, and they found out that it was easy to understand, but some scientific terminologies didn't really have any local language equivalents. And finally, they also told us that patient education in some areas are quite low. And so it's very important that these need to be addressed so that patients know how to self-manage their wounds once they're discharged. Next slide, please. I think we have 2 or 3 more. So what are the next steps? So the protocol for species has been integrated into the bigger protocol of the 2 trials, and they've been submitted to ethics. We will be having an internal pilot in Benin and Rwanda once we get ethics approval. And finally, we were able to procure a small pot of money to co-develop with patients, public and community health workers, an SSI prevention toolkit. So we got some money from the NIHR. So we are planning to do that soon, and we plan to launch that during our next big annual meeting in September in Lagos, Nigeria. So I can just skip that, but this is basically just a study that we're doing in Rwanda, where we're working closely with community health workers. Thank you, everyone, and I'm happy to answer any questions you may have.